All right, so it is just about 7 o'clock. So I think we'll go ahead and get started. Just a few reminders. So we do have the CCC meeting this week. So residents, please make sure case logs are up to date, evaluations are complete, everything like that. Faculty, please complete evaluations also, so we have those ready to go. Next week, we will not have grand rounds. So happy Thanksgiving to everyone and enjoy the week off. Today we have a speaker from UCSF. We're privileged to have him here today, and I'll have Dr. Zimmel give an introduction.
All right, good morning, everyone here and online. So it's my distinct pleasure to introduce really one of our phenomenal UCSF colleagues, but also leaders. Dr. Nguyen is a professor in the Stephen McPhee Endowed Chair in Internal Medicine. He's a primary care doctor. And he really, after attending Harvard and Stanford, completed his residency here, and then he's dedicated his whole career to really achieving health equity, both in research and patient care. In his research roles in 2022, he was appointed as the inaugural Vice Chancellor of Research, Inclusion, Diversity, Equity, and Anti-Racism here. And his research is focused on achieving health equity using various partnered methods, so both community-based participatory research and patient-centered outcomes research. And this spans using like social networks, traditional media, mobile applications in culturally and linguistically diverse populations. And it's pretty impressive. It covers quite a variety of topics, from breast and cervical and colorectal cancer screening, tobacco control, Hep B and C screening, nutrition and physical activity, and even end-of-life care. He has various leadership positions here at UCSF. So in the Helen Diller Cancer Center, he's Associate Director of Diversity, Equity, Inclusion, and Accessibility, and co-leader of the Cancer Control Research Program. And he's a PI at the UCSF Clinical and Translational Science Institute, and also the co-chair of the CTSA Enterprise Committee. And lastly, he's a PI of SF Build, which is an NIH-funded partnership with UCSF and San Francisco State. And that works to promote biomedical research workforce diversity. So with so many people here and online committed to health equity and leveling health disparities, I'm sure you'll find incredible value in his talk and expertise. So please join me in welcoming him. Thank you.
Thank you so much for the kind introduction. I'm probably not going to talk too much about any of my research, actually, and also I'm talking very little about orthopedics. I'm sorry to disappoint you. But this is the topic: anti-racism in science, health, and research. And I'm privileged to be invited here to talk about this and to do this work. I also want to acknowledge that in any group, there are people at different stages regarding the issues that we're going to be talking about today. Some of you are very committed. The goal may be to come out with some practical things that you can do. Some of you are just interested. The goal is to maybe increase that level of interest and start on that path. And some of you might just don't care in general about this, or even in opposition to it, which is actually fine. I think, if you're in academic medicine, I think it's important to remember the one of the things that keeps us here, which is curiosity and learning. So, hopefully you'll learn something, and it can also help you think about how to work with your colleagues, patients, staff, trainees who believe this or follow this path. I'm more than happy to engage, by the way. So please stop with questions. I can keep going, but this topic is not going to be dealt with in an hour. Okay. Okay. Just a quick outline. Talk briefly about diversity and equity in health and research. Talk a lot about the anti-racist, anti-oppressive framing in research and science, and then describe some of the work that we've been doing as an institution on this, again, to see if we can engage you all, and then, of course, discussion. This is actually probably one of the more important slides that I want you to take away from, which is there's this debate in this country and in science in general about diversity and innovation. Like people tend to, some people tend to say, well, diversity has nothing to do with innovation. Some of them even say, we don't need diversity for innovation. And I'm an empiricist. I like data. I want to be able to not argue. I just want to show you the data. And the data here this is probably the best study of diversity and innovation that I've ever seen. And this is, unfortunately, it's from Stanford. I'm actually from Stanford, so it's okay. But This is in the Proceeding of National Academy of Sciences in 2020. This is a near complete study population of 1.2 million doctoral recipients in the United States over the course of 4 decades. And they followed their career into publishing and faculty positions. And they use techniques I know nothing about, which is text analysis and machine learning. And what they found was that, number one, underrepresented groups, and in this case, they're defining it as women and also racial and ethnic minorities, produce higher rates of scientific novelty. So again, if there's a debate about diversity versus innovation, I want the person who says diversity does not lead to innovation to come up with a study of this size, of this completeness, and give me the data. So I just don't want to have that conversation anymore. I just want to use the data for you to use. The second thing, though, that's really important that they found was that novel contributions by these groups are taking up at a lower rates than novel contributions by those in the majority. And then equally impactful contributions are less likely to result in successful scientific careers. So this paper is more than just about diversity leads to innovation. This paper is also about, as the author said, academia, our academic system, discount diversity's role in innovation and partly explains underrepresentation. And then this is the last sentence here is not from the paper, it's from me. And the question, being scientifically curious, my question is racism operating here and how? Or sexism in this case, since women are also involved. Just wanted to show you one more paper, which is about diversity of teams. So it's not just, this just happens to be about gender and race ethnicity, but diversity of teams in general are just good. It's been amazing to me as a scientist who's doing a lot of collaborative work, how ideas just come out of anywhere, anyone in the room. And sort of as a scientist, I'm always like, most of us start with 1 or 2 good ideas, but the question is when the next idea is going to come from. And for me, it's often not you, it's hanging out with other people who are smart and who's doing something else completely, but who says something that actually gets you going, right? So this has happened to be, again, a very thorough study of basically all the publications by all the men and women scientists over the course of 2 decades. And what they found, just to summarize, is that mixed teams, this is in this case, mixed gender teams do better in science. However, we don't have as many mixed gender teams as we would like. So maybe one thing to look at is how mixed are your teams gender-wise. Other benefits of diversity, there's insider knowledge. Like I do work with Asians and I'm not the smartest Asian, nor do I know everything about Asians, but I can work with some Asian group probably with more facility than other people who aren't from that culture. There's proxy trust, which is this idea that if you don't come from that community, having a diverse team member representing you generates some initial proxy trust. And we talk a lot about distrust in research. You can't talk someone out of distrust. You got to do things to show them that they can trust you, right? And proxy trust is just one way. I mean, you don't trust someone just because they look like you, but at least you don't start out not trusting them, right? So that's a good way to approach it. It increases diversity of research participants, which I'll talk a lot more later. Obviously, role models and mentors for our trainees. And then also, this idea, which I link workforce diversity to health equity and social determinants of health, is that we have a very robust and sort of inefficient health economy. We have 17 to 18% of our gross domestic product is spent on healthcare. And actually, in a different talk, I would tell you that we also have the worst outcome in healthcare for comparable countries. So it's just a very inefficient system. Nonetheless, it's almost a fifth of our economy. So if we can actually get our workforce to be more diverse and spend that money on them or contract with minoritized companies or whatever, you can actually go a long way toward addressing poverty and inequalities in income. So I just want you to think about that, not just simply about workforce diversity, but thinking about the spending power of what we do here. Level setting on health equity. So I'm going to give you 2 definitions of health equity, and I'm going to ask for a raise of hand which one you like. So health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. And the other definition is health equity is the attainment of the highest level of health for all people. Who likes the first one? Who likes the second one? Okay, now this is actually interesting because typically in health equity research circle, they pick the first one. I actually been to meetings where I was the only one who raised their hand for the second one. I like the second one because, again, I'm an empiricist. I can measure the highest level of health. Fair and equal opportunity, fair and just opportunity, it's quite hard to define operationally. And as a matter of fact, if you remember recent affirmative action debate, we can't agree as a society on what that means. If we can't agree on it, I can't measure it. If I can't measure it, there's no accountability. There's no accountability, we're not going to get health equity. So even though, it's all these things are provisional, I like to pick the ones that actually gets us there. Equality, equity, and diversity, just again, just to level set a little bit. Many of you probably know this picture a little bit, although at least the first two frame of it. So the first panel on the left is what we call equality. Everybody gets the same, but not what they need, right? So you can stand on the same box, but some people see, some people don't. Equity is the second frame, which is everybody gets what they need. So some people get some more than others, but they all get to see the game, right? And then the last one I think is actually interesting. And this is sort of the crux of structural and anti-structural racism, anti-structural sexism, and so on and so forth. We see the barriers, we see the fence. The fence is the problem, not just the opportunities, right? So we're like, well, change the barriers, change the fence so that everyone can see through. And then I'll take it one step further and say, well, why are we standing on the outside looking in? Why are there people standing on the outside looking in? Let's bring them in. And that's where diversity comes in. I'm fond of saying, well, don't just watch the game, play it, umpire it, coach it, make money from it. When I switch over to anti-racist, anti-oppressive framing, any questions so far about diversity, equity? We're just level setting a little bit, some of the terms that we're using. There are many different definitions of anti-racism and sort of framework and structural and theories. And I'm not actually, I'm an MD, I'm not a PhD. I have no expertise in theory. So I'm going to tell you what operationally, what I think, one particular operationalization of this work. So, so this is from Dr. Kamara Jones, who was actually UCSF Presidential Scholar in 2022. And this is what she wrote about racism and anti-racism. So the first thing about racism is that she defines it as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, or what we call race, that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through a waste of human resources. And I think she follows it in this paper by saying because it's being defined as a system, we can get away from all this "I'm not a racist" thing. I mean, there's a whole, we'll talk about interpersonal and intrapersonal racism in a minute, but this is not what this work is about. Anti-racism is not against anyone. It is against systems of racism or a system of oppression. And the other thing that's really important that I highlighted here is the waste of human resources. So again, back to the whole idea of inefficiency. And the sort of the thing that I follow this with is when we talk about allies in this fight, there's no such thing. If we live in a society in which our entire society is using resources inefficiently, then we all suffer, right? So you can think of yourself as an ally. I'm not a part of that group. I want to help out. That's okay. But that's not the vesting that I need you to think about. I need you to think about that you yourself are being harmed by racism, even if you're not a person to whom the racism is being directed structurally. What does anti-racism look like? And again, I love this formulation because it's very straightforward. Name it. So in that slide on that workforce, the diversity innovation, I asked the question, is racism working here? I didn't say it's racism. I'm just naming it. I'm like, is it working? I'm a scientist. I can ask, hypothetical questions. I can do hypotheses. I can generate hypotheses and collect empirical data, right? Why do I shy away from the word racism any more than I shy away from the word cancer, right? Some people don't like the word cancer. You can't say cancer around some polite society. Yet we do in medicine all the time. We talk about poop. We talk about all kinds of things that people find objectionable in polite society, but why not racism? And then the second question is, ask how it's working here. Again, such a natural thing to do for people who are scientists and clinicians. Like, yeah, is it working? Is it happening? If it's happening, how is it happening? So then again, in that that slide, I said, is racism operating here? And if yes, how is it operating here? And you can also ask the question, well, it's not operating here. Well, why isn't it operating here? Because I would love it if you say, we have a system in which there's no racism happening here. I would love it because I would be like, well, I want to study that. I want to study how it works so that I can make sure other system works that way, right? So again, from a scientific curiosity perspective, this works great. And then, but the last thing about anti-racism that's really important is you don't just answer questions. So in science, there's this idea of like, oh yeah, we're here to answer questions. As clinicians and clinician researcher, you know that's not sufficient. We're here to fix things. I don't know about you, but I became a doctor to fix stuff. And so how do we fix this? We don't fix it by ourselves. We organize and we strategize to act. I'm not going to spend too much time on this, just to, again, to define terms. There's internalized racism, which I think is pretty straightforward. We live in a society where there's a lot of racism. We take some of that on to ourselves. We think about ourselves in ways that are shaped by racism, both positive and negative. There's interpersonal racism, which is the one that everybody thinks about all the time. So-and-so has offended me, has said this and that. And again, both of those things are incredibly important, and particularly in inclusion and belonging, it's really important. But I don't do that work. As you know, UCSF, the Office of Diversity and Outreach, which is there's a vice chancellor of diversity and outreach who does that work. I don't do that. I mean, I deal with it, but that's not my job. There's institutions, for example, UCSF and our policies and our norms and our practices. This is what I do. I love looking at all the stuff that we do and we assume to be the case. And I always ask the question, well, is racism operating here? It's okay if it's not, but I'm okay with asking the question. And you'd be amazed at how many things that we take for a standard operating procedure that were built on assumptions. And I'll show you a couple that's based on structural racism, okay? And once you point that out, people are like, oh, I didn't know that. And then again, in a genuine atmosphere of engagement, I'm not accusing anyone of anything. I'm just saying, look, this is how we ended up here. How do we fix it, right? Structure and systemic, obviously, are sort of bigger issue, our history, our economic system, our political system, our justice systems, and so on and so forth. And this particular example of an iceberg, I think it's a metaphor that I think we all get. The stuff that we see is mostly the internalized and interpersonal, but the stuff that we don't see is the stuff in the structural and institutional stuff. And again, as scientists, and most of you, I think, well, actually, most of us study things that we don't see visibly, right? Microbes and so on and so forth. Well, just because you can't see it doesn't mean it doesn't exist. And believe it or not, at UCSF, people have said this to me. Oh, why are you working on racism? I've been here 40 years. I've never seen it. This is 2021, right after George Floyd, okay? So, yeah, and I take them at their word. I've never seen it. Doesn't mean it doesn't exist. I've never seen E. coli, but it exists. Racism in health and science, biology. This is just a quick primer. I think many of you have seen this, but it started in the 1700s. The guy, Linnaeus, who was a huge scientist, modern taxonomy, he came up with a taxonomy for race. Talk about phenomenology, for human skull size. Dalton worked on eugenics to breed selective traits. And then, again, just to, orient ourselves as scientists, in 1921, which is 100 years ago, which probably is a long time to you, but very short to me, the least story in the Journal of Science was about the Second International Congress of Eugenics. So it was not fringe science. It was actual science back in 100 years ago, or at least people thought it was actual science 100 years ago. And also, we talk a lot about publishing in the best journal. Here is a publication in the best journal. But just to level set, I think we all generally agree now that because genetic variations is found more within than between racial populations, that race is not biological. Believe it or not, when I was training, that was not a settled debate. So a little bit of warning here. There's going to be some objectionable word here because I want to have some of these guys say in their own words what they think. This is a great paper, by the way. It's not really a pleasure reading, but it's interesting about how statistics was started by a bunch of basically races. So Francis Galton, who basically came up with the regression correlation and the normal distribution and bell curve. Here's what he said. Carl Pearson, who is the father of mathematical statistics and came up with the p-value, the p is for Pearson, right? So this is what he said. And Ronald Fisher, who does significance testing, this is what he says. Again, you can separate the scientists from the work, but in anti-racist work, it's hard to do that. It's very hard to separate the scientists from the work because we'll talk about neutrality in a minute, but the assumption is that the scientist approaches their work with neutrality, then their outcomes and their findings are acceptable. If the person is not coming at it neutrally from a particular point of view, then you could sort of imagine that the outcomes will be tilted toward that point of view, right? So again, maybe not consciously. Health and science research example, I don't want to spend too much time on this. I think many of you have heard of it. The main thing about the US Public Health Service Civil Facility Tuskegee is don't refer to it ever shorthand as Tuskegee. The people from Tuskegee really hate this. It's not their fault. It's the US Public Health Service that was at fault. The father of American gynecology, J. Marion Sims, made his reputation by operating on Black women, including without anesthesiology, to come up with some of his discoveries, quote unquote. Gregory Pincus studied the birth control pills in Puerto Rico, where he didn't tell people that he was doing a study, and then he suppressed adverse side effects. And then here at home in our glorious San Francisco and our own Tolan. Tolan is very famous. How many of you know who Tolan is? Well, at least you know some names, like there's Brown and Tolan, and there's Tolan Hall, and all kinds of stuff. Tolan, actually, this university was started out as Tolan. So this was the name of this university at one point. He basically blamed everything in infectious disease on the Chinese living in Chinatown, San Francisco, for about 2 decades. There was a sort of a period where they had some really bad STD epidemic, and he was like, it's the Chinese prostitutes' fault. You know, I mean, it's just this sort of craziness that we accepted. And many, many other examples of this. I'm not going to delve into it. Nature had a really nice special article, publication on this. I want to switch gear a little bit into justice and injustice. As you know, I haven't talked very much about that. I mean, I'm obviously have an orientation toward it. I can talk about this work without actually referring to justice or injustice. However, the work is integral. When justice and injustice is integral to this work. And the reason why I put this quote up here, injustice arises from social, racial, sexual, and cultural biases institutionalized in society, is to tell you, how many of you know what the Belmont Report is? Yeah, you do human participant research, you have to read the Belmont Report. If you do your city training, you have to read it. And this was done, the Belmont Report was done in 1970. So this is nothing new. There is nothing new about what I'm telling you. If you want to do BS researchers working with human beings, this is what you have to know. And they knew this in the 1970s, okay? This is not news. One of the definition of justice is fair and equitable allocation of risk and benefits, which requires appropriate representation in research studies. This is also from the Belmont Report and many other sort of human participants regulations. So, you know, the population of research participants should reflect the population served by results. Now, you could say this, well, yeah, this is a justice problem. It's not a justice problem. It's a scientific problem. If you give me a sample that doesn't reflect the population being studied, I'd be like, I don't care what you found. It's not generalizable, right? External validity, right? If you study, you know, I don't know, you can pick whatever topic you're studying, and the people you study are just 20-year-olds. Well, yeah, it might apply to 20-year-olds, but it doesn't apply to 40-year-olds or 60-year-olds, right? So just, you don't have to come at this from a justice perspective. But I do. So let's get into it. Now, what does it mean to come at it from a justice perspective? So this is a study, this is a little bit old now, but it's probably still true, that this is genomics. We think genomics is a big thing, a big field of science, huge advances. They looked at all the genomic studies in 2009 and found that 96% of the people in genomic studies had European ancestry. And in 2016, things were better, 81%. So in this country, this probably was true. And the question is, during that time, the population of white people in this country was 60%. So I want to just ask a very simple scientific question. Is it likely random that out of a sample where 60% of the people are white, that you drew samples of 80 and 90% white? Is it random or not? How many people think it's random? How many people think it's not random? Okay, so we're there, right? I actually did the chi-square on this. I used Fisher's test, even though he's a racist. I used this test, and the p-value is less than 0.0001. Actually, that wasn't Fisher, that was Pearson. So I think I've proven to you that this is not a random finding, right? And the scientists, when they see something that occurs that's not random, what do? They go, well, why? How? That's what scientists do. And so that's me. And I'm asking the question, is racism operating here? Naming it, and how? Right? Am I saying to you that this is because of racism? I'm not saying that. I am saying, though, it's a reasonable question that we should pursue as scientists. Here's another one that's going to upset some people here in this room, I can guarantee it, because it upsets a lot of people at UCSF when I do this. So if you do your IRB application, there's a section called protected or vulnerable populations. By the way, vulnerable populations out. You can't use the word vulnerable population. We're not vulnerable. You make us vulnerable. You attack us. If you didn't attack us, we're not vulnerable. Just to say that. But this is the terminology. And they say, well, the reason why we have people who don't speak English, and also you don't use non-English speakers, no one likes to be defined by what they're not. You wouldn't like it if I told you you were non-something. So no non-English speakers. People who speak a language other than English are often treated as protected or vulnerable population in the Institute Review Board, because they're like, we have to protect them. Why? Because they don't speak the language, and therefore people can exploit them. Very noble, very nice. And as me, I come in, I'm like, that's good. But what if you spoke the language? Then are they vulnerable? They're no longer vulnerable, right? I'm just going back to the idea that our system treats people as vulnerable by not dealing with the fact that we're not giving them the same thing that we give everybody else. We don't assume, we go into the room and we assume that the person speaking to the English-speaking patient speaks English. I could very well go in one day and say, tôi không biết nói tiếng Anh, tôi cần một người thông dịch. What I said, I don't speak English, I need an interpreter. Would that be is that the norm? That's not the norm, right? Well, we can approach this the other way. And so the point here that I'm making is that how you define things and how you approach things as a solution differs. The bigger point is that in most research, and I just show pediatrics and emergency medicine, I couldn't find data for orthopedics, but I'm going to assume that it's kind of like everybody else. Most studies don't mention the language that they recruit patients in. I mean, isn't that important? Like how you talk to the person to convince them to join your study? Which language did you use? You don't report it. Most of us don't. And as a matter of fact, I would guarantee you that some of you people, including me sometimes, have written studies where I don't specify the language of recruitment. At the minimum, you have to do that. I do Asian American work. There's tons of papers about Asian American based on data collected in English. And I'm like, that's not a limitation. That's a feature of the study. Okay, they put it as a limitation. They're like, oh yeah, this does not apply to people who don't speak English because the sample doesn't include people who don't speak English. I'm like, no, that's not true. That's not true. It's true is your findings are applicable to Asian Americans who speak English. Okay, that's the finding. That's not the limitation. That's the finding. I challenge that all the time because a lot of people doing Asian American work do this. Same thing with any other group. Do define the language at the minimum. And then second, ask the question, which is the bigger question, which is the thing that I'm working on with this university. Is it ethical to exclude someone from research because they don't speak the language? We do it all the time. I'll guarantee you 80 to 90% of the study in this department exclude people who don't speak English. And we think it's normal. I mean, it's like no one challenges it. And when I challenge it, they're like, what's wrong with you, Tung? Don't you understand that we have such a hard life as researchers and we don't have enough money? And I'm like, totally understand that. I'm a researcher. I struggle with budget. But why is this okay? Right? Why is it okay? It's not okay from a validity standpoint. Like, it's not generalizable. Lots of people don't speak English in this country. So your study is already limited. So your science is limited, right? We have to make choices, no question. But I'm raising this up not because I'm telling everyone has to do it. I'm just saying, ask the question. And then ask the next question, which is, if we accept this as a reality, is racism operating here? And I'll talk to you about this in terms of like how we will help you if you buy this framing. We're not here to just make people feel bad. And also, just really, finally, it's really important from a generalizability perspective that New England Journal in 2021, I assume that many of you think this is one of the highest level of science, says you can't publish a paper anymore until you have a supplementary table that describes the population that you drew your sample from, so that people can compare your findings and make it generalizable. This problem with we teach people in research a lot about internal validity. How do you know your finding is an approximation of the truth within the sample that you have? We teach that. We're like incredibly concerned. And when I go to listen to people teach about research, that's the thing. Like, what's the p-value? What's the p-value? I'm like, but if you found something that doesn't apply to the rest of the world, who cares what the p-value is, right? External validity, generalizability is the key. And I will say, this is completely unproven scientifically, that many of the problems we have with science today in our country, and the misconception and the disbelief, is because we don't pay enough attention to external validity and generalizability. We only care about internal validity. Not going to spend too much time on this. Questioning the answers is part of a talk that I give where I question everything. And I think scientists love answers. Like, I want to do this project, you can find this answer to get more. I don't care too much about the answer as a scientist. I care about the question. What kind of questions are you asking? Because that's the interesting part. What questions are you asking? And then, why did you ask these questions and not these other questions? I find that incredibly interesting. Like, a lot of us are like, oh, I study cancer because my dad had cancer. That's great. That's wonderful. But what about the other choices that you're making about what you're studying, right? And this is about neutrality. Neutrality is clearly, I'm never going to argue that you need to be as neutral as possible in the research process and research integrity, right? You can't come into a project and thinking that you want it to come out a certain way. And yet, to be honest, if you actually think about the researcher you talk to, they really do. They want to prove that their intervention works. Like, nobody goes into a study going, I'm going to test this intervention and I don't think it's going to work. I know it's going to work. I just have to show that it works, right? But let's just assume that it's good. I think this is nothing new, that neutrality is interpreted perpetuation of injustice in unjust system. This is such an important concept. So when we were in the middle of the pandemic, they're like, oh, let's do more my chart messages, care, let's do more telemedicine. And it's gonna be a good thing. It's a good thing. And I was like, yeah, that's pretty awesome. They're like, but I take care of a lot of older Asian patients who don't speak English. Like, my patients can't use a computer, have no internet access. And even if they did, they can't figure out the menu when they come in. Like, I don't know how many times you've done this telemedicine, but I'm like, hit that button so you can turn on the sound, okay? I can spend like 5 minutes trying to figure out how to turn on the sound, right? And when you do this, it's a wonderful technological advance to do telemedicine. I think over time, it's going to lessen a lot of inequities because of access barriers being lowered. But initially, when we do this, what we've just said is, if you speak English and are well-to-do, you can be safe from COVID and stay at home and talk to your doctor. And if you're old and frail, the people who are at most risk for having COVID, you have to come into the office and deal with all the sick people in the office, right? It's just, and if you take this framing, every single time someone tells you about something that's good, you see what I'm talking about. You will see. The presumption in my work is any technological advance worsens health disparity until proven otherwise. Okay, that's my hypothesis. That's my null hypothesis. Okay, and then we can prove that it doesn't, but I don't assume that it won't. Okay, that's the orientation I want you to have. Lack of trust. I just want to put this up because a lot of people who health disparities research has been around for 30 years. We're tired of describing health disparities. We're doing health equity research. We're going to intervene on the health disparities. Nonetheless, there was a lot of description in the first 10, 15 years that lack of trust is the reason why there's health disparities. How many people have heard this? How many people think this is the most important reason why there's health disparities? That's good. Lack of trust, number one, and this, I get this, like, I can't recruit these people because they don't trust us. They have lack of trust. They're Tuskegee. You know, Tuskegee. I'm like, explaining something and intervening are two different things. Lack of trust has been shown, and this is National Academy of Medicine, so I'm not just making this up. They've done a whole big review on this. Lack of trust is not a key factor in research participation. Let's stop talking about it that way. Let's talk about how do we solve this problem and not put the blame on the people you're trying to recruit. There's a very article here that is very obscure. And I only put it out because when we talk about trust and mistrust, what they did was they went to a bunch of white people, Latinos, Latinx, and Black people in New York and asked them about these various things related to trust and mistrust in research. And they came up with 4 themes. One is general trustworthiness, and then perception of discrimination, perception of deception, and perception of exploitation. So if you're thinking about working on trust and mistrust, you have to think of all 4 of these categories. But I highlighted the general trustworthiness because I don't know about you, but when someone comes to me and say, "Oh, you should trust me," what's the first thing that I do? I don't trust them, right? You can't talk someone into trusting you. That doesn't happen in human life, you know? You have to be trustworthy. You have to show, you have to demonstrate that you deserve someone's trust, okay? We'll talk about what that means. And I also don't buy the last 3 on this paper because I don't think it's perception. It's not perception of discrimination. It's actual discrimination, it's actual deception, and it's actual exploitation. Okay, so let's go to some institutional effort. And then, and just as this is what we're doing here, because I told you that one of my work here is to address institutional racism and oppression. So after the George Floyd murder in the middle of the pandemic, where we saw all these terrible health inequities, the research faculty at UCSF basically advocated for this task force on equity and anti-racism in research. We were tasked to report to the provost, and I was tasked to be one of the co-leaders. Dr. Monica McLemore in School of Nursing was the other co-leader. And we did this the way that we always do this work, which is if you think about organize and act, you want to organize. You can't just have 2 people running the show, you organize. And when you organize, it's who do you put into that group, right? So this is what we call, the term used to be stakeholders. And by the way, if you're using that term, it's out now. I don't like it. I kind of like the term, but it's now out because of implications around stake and not S-T-E-A-K, but S-T-A-K-E, and putting a claim on people's land and all that stuff. We just came up with CTSI with this new term, which I kind of like, but it sounds kind of weird. Vested parties. Vested parties. We couldn't come up with another term, and if you come up with a better term, let me know. But vested parties, and I imagine a bunch of us walking down in Patagonia vests, you know. So there's 25 people in this team that we had institutional leader, we had faculty, diverse faculty, we had community leaders, we had staff and trainees. So we believe that this effort did not only involve faculty, right? Everybody has a role to play here. And we didn't do what a lot of people at UCSF do, which is, I want to create something brand new. I want to be the discoverer. I want to be the initiator. We like, no, there are lots of people doing great work here. Let's find out what they're doing and try to leverage that work and connect with it. We were tasked to develop with recommendations to turn UCSF into address anti-Black racism. We did this. We came up with 164 recommendations. And then we presented it to UCSF in the community comments and then revised it. And that was where we got that "I never seen racism in 40 years" at UCSF comment. Out of that, one of the first recommendations was to create this office that I now lead, the Associate Vice Chancellor, Research for Inclusion, Diversity, Equity, and Anti-Racism. These are some of the people working on my team. So our charge was to develop a strategic plan on this idea. So inclusion, diversity, equity, and anti-racism for the research enterprise. We were charged with coordinating activities to increase idea among research training staff and faculty. So this talk is actually part of my work. integrating these principles into the work of the Office of Research. So again, looking at these standard operating procedure and understanding, does it promote or does it work against racism? And then to promote actual anti-racism research at UCSF, and then to be an MPI on the CTSI. How many of you know what CTSI is? We need to do a better job of advertising ourselves. We're the Clinical and Translational Science Institute. If you do any research with human beings, I strongly urge you to go to our website. We have so many resources for you. Don't try to discover these things on your own. And I know your mentors are great, but they don't know everything either. Come to CTSI. We give you a free consultation. Orthopaedic give you a free consultation. All right. This I think you probably figured out now that I like to make up words and stuff. We look at this and we're like, well, what's our job? You know, we have 164 recommendations, so I could work till I retire or beyond. But our work is fundamentally about the structures. We want to fix the structures. We have build relationship, partnerships, how to address these things. And then there's operational, and this is really important because people who work in anti-racism, particularly academics, tend to take our time. Like classically, health disparities was discovered in the 1990s. And in the 2020s, we still haven't done anything really about health disparities, right? Which is great for your academic career. You can do research for 30 years. I did research for 30 years. Oh, wonderful. I got lots of funding. The community is like, what did you do? You haven't fixed any of our problems. And that's the operational piece. I don't want to just come at this and say, we're fixing this and that. It's going to take 5 or 10 years. We're trying to fix some things right now. And want to show people that we're doing this. And again, this is the word that I made up. If you read down the first letter, is sassy. So our work, we're very sassy. Synergize, amplify, silo busting, sustain, and initiate. And I put the initiate last. I am not interested. I don't think there's still probably a role. I read an article. I didn't read the article. I just saw the headline. Like some doctor tried to treat her own cancer using some experimental method that no one's ever heard of and cured it. I'm like, wow, that's like initiation, individual. You know, my hero was Barry Marshall, who drank the H. pylori mix to prove that H. pylori causes gastric ulcers. That was when I was in medical school. I was like, man, that guy's just wow. But that's not what this is about. We're not about this. We're not about the individual. We're not about the heroes. We're about all of these other things. Lots of people know how to do this. Lots of people know how to do chunks of it. Let's organize and act. Organize and act. Okay, that's anti-racism. Some of the things I'm working on, I'll show you some of this in a minute. We have an oversight committee. So one pitch is we're going to be issuing calls for members of our oversight committee in the spring. If you're interested, please apply. We have working groups looking at things like data and technology, anti-racism scholarship, diversity, and community research. We actually took on a project where, I don't know if you know this, but there's a Press Ganey survey for all your patients. So about 10% of the patients actually answer it. So we have hundreds of thousands of responses. Like I'm a researcher, I'm like, you have hundreds of thousands of responses. Oh my God, what a gold mine! But what they found was our minoritized patients all felt worse about their care experience at UCSF than our majoritized. And in particular, those who are Asian, those who don't speak English. Now, is that surprising? No, but it's data. It's data from our own system, right? So we are trying to figure out what to do about that. One thing you could do is that you should insist on appropriate signage wherever you work. You should just keep asking for it. They won't give it to you until you ask for it over and over and over again. But the more clinics start saying, well, why the heck is it that everything's in English and there's no Spanish and no Cantonese or Chinese for Chinese? The more clinicians start arguing for it, the more likely they'll put the signs up. We talked about this idea that we don't accept the fact that people, see, I use the word non-English speakers, wrong. People who don't speak English as research. And what we do is we say, well, and actually our institutional review board actually is bought in. They're very, very good on this. And they're like, if you submit a study now, they'll ask, why is it that you didn't include people who speak English? They're not making you include people, but they'll ask. And then we actually now have language translation, that's a requirement. But then we also have free consultation at CTSI on how to do this. And we even have money for you to help translate documents. So if you happen to be in the middle of a study where you didn't think about it, but you do want to include people who speak Spanish or whatever, we can help you. We are here to help you. But we, of course, think that it's better to think about this when you write your grant and your budget. And one of the things I'm trying to do, I don't know how many of you know you do work with industry, but what I'm trying to do is get all the industry contracts to include language translation as part of the budget. Like even the researcher doesn't have a choice. We're not signing that contract unless you have provision for language translation in your study. And that's the best way to deal with it, right? Because we don't have the money to pay for all the translation that all the UCSF researchers need. There's also the whole thing about plain language documents. I have to say that I find it very interesting that sociologically, we take people who are normal people coming out of college, and then we turn them into jargon speak people. And that's actually part of the training process. It's like you have to learn how to speak like everybody in this field speaks, right? Which is great, wonderful. But then you come back out and how do you speak to normal people now? And a lot of us forgotten. We can't speak to normal people. And then this is very interesting because I train students in the clinic, and I'm sitting there watching them, and I listen to them talk, and I'm like, you're talking to me, you're not talking to the patient. You're not saying things in a way that the patient can say. That's what plain language is. With AI and other tools, it's so easy now. So easy. You take whatever you wrote and you put it into a tool, and it will tell you what grade level it's at, and you just aim for an 8th grade level. You can even ask AI, and you can't just use AI, but you can just have them do it and then look at it and fix it. Talk like a person. Again, back to the whole idea of people don't trust scientists. Why don't they trust scientists? Well, there are many reasons, but one reason is that scientists don't speak to them. Scientists only speak to each other. That's what we do. We train people to go to conference presentations. We don't train people to go to the community and explain what they do. So I had this experience where I was talking to a community leader about a project, and I was like, oh yeah, in order for us to change the culture and the community, we have to have a logic model, and we have to do this and that. And he looks at me and goes, if I can't explain to my grandmother, it ain't good. And I'm like, yeah, that makes sense, we want community representation in the IRB. There's a lot to talk about AI. I don't want this AI. I think engagement is a complete other topic, but we're trying to do some work here to establish. Remember, I just said that every new technology can be assumed to worsen inequities until proven otherwise. AI is the case study of this, okay? So we're trying to work on that at the institutional level. UCSF says, oh, we love diversity and all this stuff. And I was like, for 20 years, I've been going, well, how are we doing? We're scientists. We have the second highest NIH funding or the first highest NIH funding. And if I ask a very simple question, how are we doing with the diverse participant on university? Until this spring, there was no answer. Interesting. So it makes me wonder, is racism operating here? And just kidding. I don't know, But anyway, we did this with CTSI. And what we found, interestingly, was that this is, and I really encourage you to go to that website. And you can look at your own department. And actually, I will show you, I think, your own department here in a minute. We're doing okay with Asian if you compare it to the overall country's distribution, but not if you compare it to California. With Black Americans, we're doing okay if you compare it to California, but not if you compare it to the country. And with Latinx, Hispanic, actually the new term that CTSI just came up with is Latinay, E with a accent mark. We're doing badly. So we're just doing very poorly with that. And this is only NIH studies. We don't actually have the capacity to look at all the other studies. And that's what I'm working on. One day I'm going to be able to describe to you the entire population of research participants at UCSF. I did look at orthopedic surgery. I went to this website. And this is actually for both clinical and non-clinical trials. For Asian, you're doing good. You're like almost matching the Bay Area 9-county pop distribution and over sampling California and the United States. But for Black and Hispanic, you're doing poorly, which is not unusual. Anti-racism scholarship is a brand new field. It's a new mesh term, only lasts 5 years. We are a leader in science. I want us to be a leader in science. So we actually have a consultation program for people who want to do anti-racism in research. Just ask us for an hour. We'll talk about how to approach this work from that frame. And then we also have internal pilot grants, which we have been funding. So if you have a good idea, there's a way to do it. Switching over to diversity really quick, I think you probably already know this. This is a paper that was published in 2022 on diversity in orthopedic surgery. Big lesson is it's not great as a profession. This is for residents. So I think the actual faculty numbers would be even lower. The point here is to say, well, we can do a lot about this. So NIH diversity supplement, how many of you know what that is? How many actually have one? Wonderful, thank you. This is, if you already have an NIH grant, you can use this to bring on some diverse trainees, and I'll define who they are in a minute. But also PIs who have become disabled can also apply for one of these. Most NIH grants are eligible, depending on the institute, but you can assume you're eligible until somebody tells you, until you're not eligible. These are the people, they cover various underrepresented racial ethnic group. Asians are not, but there's a clause that we managed to get into the NIH that says if the institution defines it as being underrepresented, so Southeast Asians are underrepresented and Filipinos in research, so we can put those people who fit those categories in there. Disabilities, people from disadvantaged backgrounds, and women faculty, it turns out. Again, this varies by, this is the general program announcement, but it varies by institute, so I will always encourage you to check in. And we've done a little bit of work on this. Diversity supplements are actually relatively easy to get. You know, funding for NIH grants something like 10–15%. Diversity supplement is something like 50%. It's really worth the effort if you have somebody you want to support. But at UCSF, you know, when we started this work about 4 or 5 years ago, we had about 450 to 500 eligible grants. We had like 5 to 10 diversity supplements a year. So that's like 1%. Our goal, which is to get it to 5%. And so far, we've been kind of successful. We went from 12 in 2020 to 44 in 2023, which is the last complete year. And in the process, brought in not only diverse participants, diverse trainees, but also lots of money. So you know, this is a win-win for me. Diversity, more money. I don't know how to argue against that. Okay, so why am I telling you this? There is an info session tomorrow that today's Wednesday, no, on Friday that I'm also presenting at on diversity supplement. And we don't just talk about it, we do matchmaking. So matchmaking event is speed dating on steroids. We have like 100 faculty and something like 100 students from all over California. They go on 5-minute or 10-minute speed dates. And at the end, hopefully you find a match. And the match then can either come into your lab or with the intention of writing a diversity supplement. Or we figure, you know, if you met a nice person that you like and you had money, why not just take them in anyway without the diversity supplement? Because that, you know, that's the other thing is I want to diversify, but I don't know enough diverse people. Well, we can introduce you to some. The trainees are also information there. I'll send the slides around. SF Bill was mentioned as a collaboration. San Francisco State University is, how many of you actually been to San Francisco State University? They're like down the street. not really, not down the street. They're like across town. I like to come up with like funky saying that make people go, huh? I'm like, if you want diverse people, you should go where they are, not where they're not. This is, and then we're like, oh, of course, that's so obvious. What are you talking? I'm like, yeah, and you're recruiting from Harvard. How diverse is that student population? What about Cal State? Cal State, where? Like, there are like thousands of historically underrepresented STEM students at State. And even if you have an elitist bias, there must be a couple of hundreds of them who are really, really good. I will tell you without question that the best student at San Francisco State is the equivalent to the best student at Harvard. Better because I went to Harvard. But we don't do this. And this is what this grant is all about. Is we're building capacity with the institution, making sure the students are being brought into UCSF. But there's also a fundamental underlying concept behind it that's actually very important. which is that we think about bringing minoritized students or trainees into our system and try to help them. Now, that's incredibly noble and important. But what about them helping us? What about them pointing out the flaws in the way we do things? What about them contributing in ways that we can't contribute, right? And this is what we call a deficit versus asset. People who talk about pipeline programs tend to think about, and this is just metaphorical. By the way, I was born not speaking English. I didn't speak English until I was 11. I'm endlessly fascinated by the English language and metaphors. But when you use the word pipeline, imagine what it means to tell someone, we want you in a pipeline. We're going to take you and everything that you are. We're going to see this little hole that you need to fit in. We're going to shove you through it and push you out to the other end. And if somehow you don't come out the other end, you're the failure. That's what pipeline programs are. If you don't come out the outcome, you're judged. It's a training program. You didn't succeed. That is not the way we want to approach minoritized. And there's a reason why pipeline programs do work, but they don't work as well as they should. We think about this metaphor, my colleague says, I didn't come up with this, it was them. It's great. A stream. We're in a stream. We're getting to a stream. And person may get off the stream at this low destination or that destination. They get to row the way they want to row. And all we're doing is providing the water and the current, right? And they can be successful. I mean, I have many colleagues who I collaborate with in the community who have PhDs who end up not doing academia. Partly because maybe it was bias against them, partly because they didn't think that academic was where they want to be. You know, there are a lot of great people out there. If you get a PhD and you're not ending up in academia, that's not a failure. That's, to me, more capacity to do other things. So we define outcomes differently. One big thing, we have a great program called the Circle program. We take a bunch of postbacks, master's students, community members, because you don't actually need a bachelor's degree to be a clinical research coordinator, train them to be clinical research coordinator, and then help them apply for jobs at UCSF. Now, my son graduated from UCLA, applied for a job as clinical research coordinator at UCSF and got it. He didn't know anything about being a clinical research coordinator, but he came from UCLA, so big whoop. We train these students, so when they apply, they already qualify. You know, there's this elitist bias again. Like, if you're from a great institution, you're better. Well, we're like, well, they're from San Francisco State, but they're trained. So when you're looking for jobs, this is how we try to level the playing field a little bit. We do a lot of national work, which we don't need to talk about, but I did want to say that I helped us to get this EIA prize, and I didn't do any of this work, but this is all of you. And I can show you the data, how we have done such a good job, even in a state that has Prop 209, where we can't do affirmative action. We actually have double our numbers and are doing really great. And the point that I'm making here is, even though this country looks a little dark right now for those who are doing the kind of work that I do, I don't believe that it's going to be dark forever. We can keep on doing this work. Thank you. I'm going to stop. Some resources.
And I really kind of, that comment resonate with me, that every new technology, we need to evaluate first and see what it does in terms of creating racism. And I will share with you some of the clinical challenge we have. We obviously is a surgical department, so, we get consent all the time. And language is an issue in terms of getting consent. And we as a department try to do some interpretation of the consents in the past and instructions. And we did that prior to COVID. And we actually have some, Chinese, some in Spanish, consent forms for, particular groups. as the technology evolved right now, it's become e-consent. So everything's electronic, everything's English right now, and it really kind of creates a challenge for the the patient we're dealing with. What are ways that we can make it better? I think you mentioned a lot of technology that allows us to do translation system-wide. This is a problem, and basically I'm asking you is that how could we actually expedite some of these changes? Because Epic is great, but Epic creates a lot of disparity because people can't even read, their own medical records and know where their appointments
So
are.
you're saying that the e-consent is only in English and they can only access it through Epic? Okay, so that's just that's a problem with forms, right? It's technically not a hard problem to solve. It's, when it comes to system change, sometimes the problem is hard to solve technologically, and sometimes it's hard to solve from a culture change perspective, right? I'm more than happy to engage with you all in an effort to work on our healthcare leaders to make this unacceptable. It feels unacceptable to me. And I think it's an easily solvable problem. The cost of translation is dropping precipitously because of AI. We are actually now approaching translation with AI as use the AI to translate and have a community person review. We don't have to spend time translating anymore. We don't trust AI to do the translation. So translating the documents will be a lot cheaper and a lot easier. So then it's a question of making sure that it comes up on your whichever workflow that you have. It's a technical problem. It's not a technical problem. It's a cultural problem. And I'm more than happy to engage with you all offline on how to approach the health equity division at UCSF to make sure this happens.
Yeah.
All right, so I think we'll wrap up there, but thanks again so much for being here. This was really great.
Thank you.